The viral infection we are going to discuss now is Cytomegalovirus retinitis. As usual, we are going to start with introduction. Infection with cytomegalovirus, a herpes virus, is very common in the general population, causing no or minimal constitutional symptoms in most healthy individuals. CMV retinitis is seen in patients immunocompromised from a very different causes. It is a common opportunistic ocular infection in patients with AIDS, in whom it may represent reactivation of latent infection. Without treatment, severe visual loss is essentially inevitable. Since the advent of antiretroviral therapy, the incidence and severity have declined, though the prevalence remains high, partly due to increased survival rates in AIDS patients in whom systemic steroid therapy may be a risk factor. There is a very strong association with the low CD4 count. Systemic features include a range of organs, including the lungs, central nervous system, and skin, and they usually occur in the immunocompromised patients. Our area of interest is the ocular involvement, and in clinics, patients usually present with the complaints of reduced visual acuity, and that happens because of macular involvement or with the floaters from retinitis. One eye is usually affected initially, progressing to both eyes in 50% of patients if it's left untreated. Indolent retinitis frequently starts in the periphery without symptoms and progresses over weeks. On examination, anterior uveitis can occur but is usually mild with little or no injection. Cataract is a common later stage finding. Vitritis is typically mild except in immune recovery. Now, retinitis, the characteristic appearance is one of those uh, two areas of dense white retinal infiltration associated prominently with flame-shaped retinal hemorrhages, and it's usually described as a Pisa pie or margherita pizza beginning peripherally and extending along the course of vascular arcades. I'm going to show you the uh, presentation of these in different figures. And peripheral areas tend to appear granular with fewer rounder hemorrhages and little vasculitis. Indolent, more peripheral and less aggressive, as shown here in this picture. It is away from the macula, but it's peripheral. Patient in this case usually will present with possibly with floaters and fulminant, as it is shown here in this diagram. There's a typical, this arrow shows a granular presentation, and there is special granular appearance. Vasculitis is very prominent here, and it is along the arcades. Clinical patterns. The visual acuity can be significantly reduced if the macula is involved, as we can see in this picture. So, vasculitis has involved the macular area and these exudates. So, in this case, patient will present with severe visual loss. Um, Optic neuritis may result from direct spread or from primary involvement. Retinal necrosis is evident in areas where active inflammation has settled, uh, leaving irregular pigmentation, atrophy, and holes, frequently leading to retinal detachment, a major cause of visual morbidity in up to 51% of the cases. There you can see such a big hole, and it is underneath this vasculitis pattern. Again, the granular pattern is very evident, and frosted branch meningitis describes marked vascular sheathing that occurs in about 6%. Again, in the same picture, this vessel, this appearance, this is called frosted branch meningitis. Underneath this vascular sheathing reminiscent. This appearance is seen in other conditions as well, and the term is used for distinct idiopathic disorder, which is primary frosted branch meningitis. Immune recovery uveitis, IRU. This is a cause of limited visual outcome in CNV retinitis, thought to be due to rejuvenated immune response against residual viral antigen following immune reconstitution with ART. Manifestation can be severe, progressing to phthisis in some cases. Now coming towards treatment part, close liaison with an infectious disease physician is critical. Antiretroviral therapy is the mainstay of management, restoring the patient's innate ability to suppress CNV activity. Discontinuation of antiviral treatment is considered when the CD4 count reaches more than 100 to 150 cells per microliter. Well, ganciclovir is a prodrug or ganciclovir that is taken orally and is as effective for both induction 900 milligram twice daily for up to 3 weeks and maintenance style 900 milligram daily. Neutropenia is a common side effect due to bone marrow suppression, but can be effectively treated with filgrastim, which is a granulocyte colony stimulating factor. Ganciclovir, foscarnate, and cytomegalovirus, given intravenously, were formerly key therapeutic agents, but substantial side effects have been strongly led to their regulation to reserve status. Ganciclovir's slow-release intravitreal implant is now less commonly used, but still has utility in situations such as intolerance to systemic treatment. It is as effective as intravenous therapy, and the duration of efficacy is about 8 months. This is shown as an implant here, and intravitreal injections of other drugs such as fomeversin and cytoprovir may occasionally be indicated. Vitrectomy with endolaser demarcation and silicone oil tamponade is successful in around 75% of CMV related retinal detachment. Now we come to steroids, which may be required for immune recovery uveitis, and though intravitreal and systemic administration should be used with caution for HIV patients. Now, in these cases, prognosis is poor despite treatment, and that is because of regressing retinitis even after treatment. Um, Under any circumstances, when the macula is damaged and we cannot restore vision, uh, as you can see in this diagram, this has already happened. So, vision prognosis would be poor in these cases. So, screening for patients with low CD4 counts should be done 3 monthly if the CD4 count is less than 550 microliters, less than 50 per microliters, 6 monthly if it is between 50 to 100 per microliters, and yearly if it is more than 100 per microliters. So that's it with the topic of CNV retinitis. I think it's helpful. and most of the cases and some of the concepts will be clear. It's difficult to remember the drugs in most of the cases, but I think the two major drugs uh, besides ART are Ganciclovir and Ganciclovir. So we are going to have to remember that. And uveitis is majorly posterior. So uh, the typical piece of eye appearance is characteristic. So if you like the lecture, please subscribe and hit the like button. Thank you all.